hello, good afternoon, everybody, and let's all be a little excited for the first day of World Congress Diabetes India. Welcome all of you to my hometown, Ahmedabad. Now it is my hometown, and welcome to our Diabetes and Women Interest Group. Bhavtarini ma'am, all respect to you. I don't know, it's going to be a little difficult debating against a topic which you have established. So I am going to talk to you all about the universal screening for gestational diabetes. With a raise of hands, let's just raise and say how many of you are in favor of a universal screening? Ma'am, thank you. And Bhavtarini ma'am will tell you how we are debating and how the topic is different and why the debate at all. So, points or share? Okay, okay. Slide change now? Yes, thank you, Anna. Thank you, thank you. So when we talk about gestational diabetes, we understand that it is a major public health problem. All of us agree on that. All of you raised your hand. It is necessary to have a universal screening. What is necessary is a standardized universal screening rather than a selective, rather than a tailor-made approach. What do we mean when I say universal? Do we mean entire India? Do we mean the entire globe? Do we mean entire Southeast Asia? What do we mean by the universal thing? So we mean every woman with pregnancy. We do understand that the word universal here is of important when we are going to debate this now. I am also going to emphasize on the word screening. Screening are tests that will help us find the problem, screen it early, diagnose it early, and it makes it easier for us to treat the condition earlier. Now, this is an actual version, the table we've seen everywhere. How DIPSI criteria, how the IADPSG criteria, how the ADA criteria, the WHO criteria, all of them have different fasting diagnostic criteria. But what is important? Everybody talks about screening. Everybody says that it is important to screen. Now, look at the number, the population of India. It's a huge, staggering number. But what is also very important is that we, Indian women, are at an 11% higher risk of having gestational diabetes or our pregnancies being complicated by hyperglycemia in comparison to everybody else. Ma'am, I'm going to quote you here. It was ma'am's paper that is saying that even in the Southeast Asian population, 1 in every 4 pregnancies is complicated because of hyperglycemia. And this is, ma'am, the DIPSI paper being co-authored by your kind self, ma'am. Now, let me talk to you about the HAPO study. Why did everybody start talking about this universal screening? So now there are a lot of studies that are telling us that if you manage the hyperglycemia in the mother well, you are keeping away the complications, keeping away the adverse outcomes, both maternal as well as neonatal outcomes. Agreed? Yes. So that is unanimous. So now that's how the conclusion came. Universal screening is going to ensure early diagnosis, keeping all the complications away, and not just the peripartum or the postpartum. We are also looking at 5 years down the line, 10 years down the line, complications of NCDs of the mother as well as the child. Let me take you to what happens when we have a selective or a regional or a tailor-made approach. Now, what do I mean when I say selective and tailor-made? So they are based on the risk factors that the women might be having. On the basis of such a tailor-made approach, we sometimes miss diagnosing certain women. Based on the BMI, based on family history, sometimes we might fail to screen the women who actually might not have the risk factors, but might still have the genetic predisposition of having hyperglycemia in that pregnancy. For example, we are not even accounting for the migration. A lot of different diaspora is settled in Gujarat, and a lot of Gujarati diaspora is settled across the world. We are not going to account for that migratory problem. We are not going to account for any lady who might not have visible or accountable risk factors. Especially in India and China, that's what the paper reads. This is an actual systemic review and meta-analysis that says that selective screening might miss almost 20% of the cases with hyperglycemia in pregnancy. Now let's look at the public health aspect. We have another interest group on public health just parallelly happening. Undiagnosed GDM cases are a burden on the economy, not just for the current time, but again, in the next 2 decades, these kids these mothers with hyperglycemia and pregnancy are going to add to the economic burden. Preventive care through universal screening method is going to help in making the entire healthcare system of NCDs, making it cost effective and reducing the long-term healthcare expenditures. Ma'am, DIPSI is equivalent to universal screening, and that is why the DIPSI method came to strengthen the screening, the feasibility of the entire universal screening. And it is making it effective, it is making it patient friendly, it is making it effective for the rural, for the urban, for the unreached area, and that is why we are incorporating the DIPSI guidelines. DIPSI is one of the most pragmatic, scalable solution for universal screening, ma'am. And standardization does not mean that I'm not going to account for the regional changes, the cultural adaptation. It only means that I'm making it more practical. I'm making a good framework for both maternal as well as neonatal outcomes. Now, I'm just going to add on here about Tarini ma'am, that universal screening again is not going to prevent the adaptation of the local needs. We are just talking that let us not have selective screening. Let us have it for every woman who requires a screening for hyperglycemia and pregnancy and GDM. A global standardization is what is the need of the hour. The future, where are we all standing? We are standing in a conference today of something called Diabetes India, and not diabetes Gujarat or not diabetes of a particular region. We are talking about everyone getting equitable access to healthcare. We are talking about every woman, every child with a pregnancy which is complicated by hyperglycemia getting access to proper universal screening at the point where proper healthcare can be given to prevent long-term complications. So again, I'm going to say that the economic and health burden of universal screening is going to be very much cost-effective in the long run, and I am going to advocate for that. I am saying we might be different, but we are still the same, ma'am. We are all the same, and we are talking and advocating for the better health of women all across the world. Thank you, ma'am.
Very good afternoon, everybody. Actually, Dhruvi, so much thanks for you to making DIPSI a universal criteria. It should happen in the future. But what I am bothered is, I took it that we cannot make it universal any criteria. It should be regional. That's what I am going to argue with you. You are in the best and banting period where you're saying that universal is possible, but now things has changed. And coming to the, no, I need the slides. So, Dhruvi, please understand that we are second in the top 10 countries and we need to move back. We cannot do all what others say and still go to the first. And we have changing face in India and epidemiology, rapid urbanization, industrialization, income levels are increasing and change in the lifestyle values, culture, obesity. And that more of obesity and overweight we have. And for the same body mass index, Asians have a higher risk of developing diabetes, and we have got early origin of insulin resistance, and at the lower age we have a high insulin resistance as far as the Asians are concerned. Though we may look thin with less BMI, we are metabolically obese, and we can't have something universal where they say that the cutoff values are different. We develop diabetes at a very young age, progress very faster. We have high abdominal obesity and increased insulin even at low levels of body mass index, and the beta cell dysfunction occurs quite early. And again, we have ethnic specific BMI cutoff values And South Asians are at a higher risk of developing diabetes, and even the waist hip ratio, waist circumference, all are different for us, and our diet is different, which increases the prevalence of these disorders, especially in Asian Indians because of their changing lifestyle and sedentariness. And even at the time of diagnosis itself, you see our Asians have a increased cardiovascular risk, and the CVD mortality is very high among the Indians. And you see this Indian central obesity, which is very famous. This is not standing with us. This single generation, it is transmitted from generation to generation. And the typical dyslipidemia, what we have, this is different from other countries. We have hypertriglyceridemia and more of low dense LDL. And you see the South Asians, they have incidence and of fast progression of the renal disease, so we have to act fast. And again, if you take the treatment pattern of us, we respond more to combination therapy. And again, we eat more of carbohydrates, you'll agree with me, so we have more incidence, and we cannot have the criteria what other countries are having. Not only that, even after taking more carbohydrates, we are more sensitive. Also, the glycemic index is more in our Asian Indians, and we respond to drugs like alpha glucosidase inhibitors, glipsin better because of all this. And we respond to a lower dose and better at lower dose, and we have ethnical variations, genetic differences, and polymorphisms. And Dhruvi, we already have all this different criteria, the ADA, ESD, ACOG, WHO, NICE, UK, National Diabetes Data Group, IADPSG, TIPSI, FOXY, so many. Why we have come out with all this? It's all regional. It's not universal. And every country has its own. American, Canadian, National Diabetes, Europe, Australian, Japan, German, Diabetes UK. It's because of the regional differences what we have. And stepping down from ivory towers to ground reality, if you take India, we are very poor, and 80% of the population is in the rural, where we have huge crowd to tackle. We cannot have the criteria what they say to come in fasting and have forced blood samples. And this is not the only investigation what we do during pregnancy. We have plenty of investigations to be done. And medical officers are very scarce here. They have to wait for a long time, and they come from interior of the villages taking care. She is the homemaker after taking care of her house members, and also the domestic animals what she has and again, she does not have the frequent transport facility, like asking them to again and come and again to have that universal screen body you advise, like IAB, PSG or other things. And they are all very poor daily wages. They already are accompanied by another person, 2 wages gone for a day. Sometimes she may be the breadwinner of the family. So if you ask them to come again for the universal criteria and fasting, it's very difficult for them to come. And they're in a long waiting period where you cannot accept that to be done in fasting. And elders in the home believe that the pregnant ladies should not fast for a long time. And as you rightly pointed out, we are 11 times more prone. And here we have more genetic predisposition. We have late marriages. After that, they still delay the child. More PCOS, strong family history, increasing incidence of GDM, and also pre-diabetes. Diabetes itself coming first detected during pregnancy. All these necessitates that we cannot go on the risk-based basis like how other countries follow. We need everybody to be tested, as you said, as universal screening, and again convincing the patient to come again in fasting and have 4 blood samples. It's very difficult, so only we have come out with the DIPSI, which you promoted, the single test which diagnoses every pregnant woman with the GDM. And of course, even if you say that we accept, we do not have all the facilities, we do not have adequate reagents, adequate staffs, even the water and electricity scarcity are there. So again, waiting in fasting is very difficult for a long time. Such a long time, our country is different. We cannot go along with that. And there is inadequacy everywhere. So what Albert Einstein said, all these complicated problems can be solved with a very simple solution, that is having regional guidelines. That will be the best what I want to say. Thank you.
Thank you so much, ma'am. It was indeed a very exciting and energizing debate.
Of
Yeah,
course,
yeah, with the raise of hands.
Meena, it's already
Both.
done. They have already divided as regional. We need not do anything.
So I think again we are same but different, and we are different but same. Yeah.
Very cleverly, Dhruvi has taken the other
I don't
universal.
think there is any debate here because both of them are saying the same thing. If you see the global, then it is regional. So it is South Asia. When you talk about India, we can't have regional. So it's
So God Himself has not created anything universal. He has differentiated into Asians, Africans,
so,
Caucasians. All
yeah,
that
that's why
why
I
He has
said.
done.
So it's
Creator
better
Himself has done.
we talk to our own country, and when we it's a country specific guidelines, and we have got but okay, so she wanted to be universal. So that way I don't think there is any confusion. The message is very clear that every woman in our country should be screened for GDM, irrespective whether they have family history, irrespective of their age, irrespective of their bad obstetric history, irrespective of anything. Every woman should be screened at the first given opportunity, and that's what the message is. You should screen at the first trimester, second trimester, third trimester if the first and second is negative. So that's what is the message. No
So, but
confusion. Both
here
of you are
it
the
is.
winners.
Yeah. Of course, here what we mean is whether we need to follow the same universally or regionally. I say it is regional.
I don't think we should have a criteria for Chennai different. Should have a criteria for Nagpur different. I don't think we should have a regional criteria for Nagpur. Let us remain united and be focused. I
So
feel
let
that's
Dipsy come as a
Dipsy
universal.
everywhere, and that's why we have a Prega talk for awareness of people across the country in their own languages. So that's what we are making already universal on behalf of Dipsy. So we already accepted it. Right? So let's give big hand to both of the debaters. Wonderful. Thank you.
We move on to our next speaker, Dr. Purvi Chawla from Mumbai. She's going to speak on the topic Future Activity Planning for Diabetes and Women Special Interest Groups 2025. Dr. Chawla is consultant diabetologist, director of clinical research, Lina Diabetes Care, Diabetes and Beyond, and Mumbai Diabetes Research Center, Mumbai. Consultant diabetologist VLSR, the clinic, Bharatiya Arogya Nidhi Hospital and BSES Global Hospital, Mumbai. Chair at Diabetes and Women Interest Group, Diabetes India, and social media editor for International Journal for Diabetes in Developing Countries. Without eating a lot into your time, over to you, ma'am.
Thank you so much. So just by show of hands, can I understand how many of you found this session good, useful? Some feedback? Some feedback. All of you have stayed put. Great. So I think we need to work harder and then have the entire room full and also get everybody's hands up. Okay, so I think I am thrilled beyond words that we were able to address such different topics that don't always make it to a national conference. And they were done with a lot of elegance and really brought out those finer points that we were hoping they would. So I'm really particularly thankful to, of course, Dr. Sunil Gupta sir, who's our advisor. He will continue, we will keep chewing his brains for more and more guidance and road mapping. But I'm particularly thankful to Dr. Shanmugavelu sir, Dr. Abha Gupta, Dr. Ripan sir, Dr. Meena Chabra ma'am, Dhruvi, my dear friend, Dr. Bhavtarini ma'am. Fantastic session. I'm really thrilled. The topics were very well handled. And talking about the future, I'm so happy to share with you that just 2 days ago, we were able to kickstart activities for this group with our very first webinar. It was like a warm-up activity with our very first webinar focusing on, again, very different topics and things that are not very regularly highlighted or talked about. And we had, hello? And we collaborated with the IDF Southeast Asia experts, and we were really grateful that despite it being in the evening, they all managed to come together for the webinar, and The panel on pregnancy as a window to future chronic disease was also really fantastic. And a lot of insights and a lot of homework for us has come out from that, because we need to, I think now there is enough awareness in this particular aspect, but now is the time to actually act upon it. So yes, that was like the perfect prelude to this World Congress. And the aim and focus of this particular interest group is to develop and emphasize a gender lens, so to speak, for conditions like diabetes in women, as clearly it's different, difficult, often dismissed, and associated with more death. So definitely requires that specific gender lens, and that's our aim, to make everybody aware and address barriers as well as improve practice standards with a special focus on women with diabetes. And also, so not just the patients, but we want to take healthcare providers ahead too with this initiative. And to achieve our aims, we will have several webinars. We have collected some funds for the same as well, so that we can just start moving forward with the activities. Short videos from all our experts to make awareness more easily accessible. Use of social media, pamphlets, uh, and various sessions in such lovely world congresses that wherever we can get an opportunity to present, our team will be there, or we will have other representatives also who can come forward and present their work. Definitely to gather more evidence and to improve our management and prevention of these conditions. Of course, teamwork and collaborations again are in the offing. We already have buy-in from some of our Southeast Asian experts who we spoke about that day, and many more also in the pipeline working on that. So what I have done is just divided different aspects that we want to focus through this year, and not really, talking about, oh, we are going to have 3 webinars, we are going to do this. We will do whatever it takes to sort of fill the gap that we find exists in this aspect of women and diabetes. So nutrition and exercise awareness and tips, when we were having our internal co-meeting, we found that particularly for women on the go, there's not much that they can really refer to. And we plan to come out with we have a nutrition expert on our core team, Dr. Meenakshi Bajaj, and we do plan to come out with a recipe booklet specifically for that. We also want to adapt the Thandav sessions, which are the high intensity interval training sessions for women again who find it very difficult to incorporate exercise in their routine. This can be a great start and a great maintenance as well. The importance of strength training, again, as you all know, is very poor among women, especially middle-aged and the elderly. And we plan to sort of bring that forward in this age group. And our focus will be on women in the preconception period and the elderly with this particular initiative. Sexual dysfunction, again, not many things are talked about here, but we do want to do some surveys, both patient-based as well as physician-based, and we want to assess what exactly is missing and how can we help to bridge that gap. There will be definitely more awareness on this aspect, but also breaking the hesitation, the bias, and the barrier against talking about it or reaching out for help. Women diabetes and cardiovascular health, I think several studies in the West have come up. In fact, today there's a California-based female cardiologist who I follow on Twitter, and I really love her work, Dr. Martha Gulati. She just tweeted that it's only 1/3 or less than that representation of women in all the clinical trials, right? We never have the numbers. We just know, generally speaking, that we don't have much data on women. But I think we need to undertake such large initiatives in India itself. And if our group can come up with a study plan, we can definitely collaborate with a larger body and a larger association to make it happen, because everything requires some funding, some clout, and some networking. So we plan to do that as well. Bone health, again, this is an aspect of women's health that often gets, pushed aside. There's not much awareness in India, especially unless you've had a fracture, then you know something about it. So we do want to talk about postmenopausal bone health assessment. We have already planned something and we will roll it out soon, and you'll know when it gets done. So potentially there are 3 studies that are coming up in this aspect of women's health. Perimenopause and menopause, again, I would very honestly confess that India is not very much up there in terms of awareness. And that's why, Dr. Meenu Chabra, we wanted you to actually highlight the connection with diabetes and even managing it around that time. So we want to look at quality of life review in this period. We will have more awareness camps, and the need for supplementation, and if there is adequate supplementation going on in this population to begin with. Technology. Now I actually presented at the ATTD just a couple of years ago, just from a single clinic database, and found that the disparity in technology adaptation is not so much in type 1. It's a very small number comparatively, so not much can be concluded, but type 1 was still doing better than type 2. Like CGMs are definitely not that well adapted in women with type 2 diabetes. So we need to actually assess a nationwide, sort of understanding whether we are able to have some equity and equitable, use of technology and adoption across the country. So we will help to address those gaps as well. And type 1 diabetes and obesity, not both of them together, but these are subgroups that again have come up in our discussions that we would like to focus, understand the biases, because there's a lot of work going on. We don't want to replicate work that is already being done, but we want to help them supplement that. So we would like to highlight if there are biases and actually help to mitigate those. So based on the learnings of some of the gaps that we have already identified and some that we plan to assess with surveys and other studies, our programs and activities will be fine-tuned. I'm not sharing much. We have already made some headway. There's something that's just going to be initiated, and some are in the near future. We'll discuss more, get some more guidance, and then go forward with that. So with that, the entire group is very thankful to Dr. Shanmugh Gavelu sir and Dr. Sunil Gupta sir for always having our back and helping us move forward in this direction. Thank you so much.